Welcome to the ICCS YouTube channel. Today we're going to be interviewing Dr. Jean Oak, who's a hematopathologist at Stanford University, where she directs a flow cytometry laboratory. Jean is a lead author for a recent publication from Clinical Cytometry on a practical approach to panel design, validation, and interpretation for the evaluation of T-cell neoplasms by flow cytometry. This is a collaborative effort bringing together a number of different authors from different institutions, and we're excited to hear more about the article and its contents from Jean today. Now, before we get to our conversation, I'll tell you a little bit about the article. It contains lots of useful resources if you're evaluating T-cell neoplasms in your laboratories. There are a number of tables that are of value. For instance, we have here Table 1 and Table 2, which list first the different types of T-cell neoplasms you might encounter, and then the antigens you might want to evaluate if you're diagnosing these diseases. The antigens are divided into those that are core or backbone antigens and those that are reflex or optional. And I'll mention that the portions of the tables that I have here are just partial. If you'd like to see the full table, please refer to the manuscript. We also have in a table the diseases which come together with the various antigens, and we have lists of distinguishing immunophenotypic features and the core panel that you'd want to use to make any of these diagnoses, along with reflex or optional antigens you might consider adding in different scenarios. In addition to useful tables, there are a number of dot plots and histograms that may be of use to you. For instance, here is an example of Figure 5 from the paper, which contrasts normal patterns of antigen expression from those seen in reactive settings. And these are then contrasted further with the abnormal patterns you'd see in T-cell neoplasms. And then we have lots of examples of the use of TRBC1 and 2, which are becoming more and more common in clinical flow cytometry practice. So if you're bringing these on in your laboratory, it will be useful to see how these are being used and how they can be best utilized. Finally, they present to us a figure which gives a diagnostic algorithm one can consider when evaluating abnormal T cells. And last but not least, we have the supporting information. This is sometimes overlooked, so I just wanted to highlight it here. Within their sort of supporting information, Dr. Oak and colleagues provide lots of useful resources, including a number of T cell panels and layout examples from different laboratories, as well a checklist you can use if you're evaluating T cell neoplasms and starting to develop your template for evaluating these. And then finally, a list of case studies that can be helpful. So with that, let's get into it and welcome Dr. Oak. So welcome, Jean. Thanks so much for being part of this YouTube channel and joining us for an interview. Could you start by telling us a little bit about yourself and how you got interested in T-cell neoplasms?
Yeah, so thanks for having me. Hi, I'm Jean. I'm a hematopathologist and the director of the flow laboratory at Stanford. Um, Before I was a hematopathologist, I actually used to study T cells. So T cell neoplasms always had a special place in my heart. So I'm very happy to be talking about T cell neoplasms today.
So full circle back to T-cell neoplasms.
Yeah.
That's great. So this paper is wonderful. I just was able to read it recently, and I'm wondering from your perspective, what do you think is one of the biggest takeaways you'd want a reader to take home and incorporate into their practice after reading the paper?
I think the one of the biggest main reasons why we put together this paper was as a laboratory is to really provide a comprehensive resource for flow cytometrists who are interested in doing the next level of T cell analysis and how to incorporate difference from normal methods because while when they especially particularly when they're bringing up TRBC1 and 2 because there's going to be a lot of caveats that come with that to kind of get and so in the introduction of the paper, thank you for doing that, by the way. You actually go over many of the different kinds of case figures that we have and the resources that we have. We also have a list of case studies in the supplemental section, as well as analysis templates that you can download and use for your needs as well. And here's one of the case studies to show how one of the analysis templates function for T cell analysis. One of the first things that we do when assessing for T cells is start by assessing the CD2 by CD7 gate, and the overall fraction of T cells, and the CD4-8 ratio shown here. Here you can see that the 4-8 ratio is quite high. Next, we look at the expression pattern of the pan T cell antigens, which are shown in the y-axis here. And you can see here there's a population that is slightly dimmer for 4 and maybe a little bit for CD3, a little brighter for 2, completely negative for 5, and kind of smeary for CD7. If you look at putting that information aside, if you then looked at the TRBC1 expression histograms, you can see the CD4 population is markedly skewed and below at 4% of TRBC1 positivity, which is below the recommended 15% cutoff. Now, if you took this population that looks a little abnormal, that is negative for CD5, shown here, see that. You see that this population is completely negative for TRBC1. This analysis template is also configured to calculate and report out the percentage of the abnormal cells relative to lymphocytes and CD4 positive events, which we recommend to kind of report out when you are used for peripheral blood, so you can calculate out the absolute count, much like how we do the calculations for B cell neoplasms such as MBLs. We also report out the relative percentage of non-blood specimens as well, but the utility in those specimen types is less clear.
So one thing that I'm taking away from this
Mhm.
is that you're using the difference from normal approach from the immunophenotype in combination with TRBC1,
Yeah.
and you shouldn't really use TRBC1 without knowledge of the immunophenotype. Do I have that right?
Yeah, that's actually one of the major reasons why we have figure 5 in our paper, because again, it is really important. So TRBC1 and 2 are kind of like kappa lambda in that, and they are essential, but they are not sufficient to diagnose an abnormal population. So figure 5 goes over the different patterns. And for T cells, a lot of the core antigens that we recommend in table 2 are going to be, the changes are often kind of subtle, but you need to be able to recognize them. So, and figure 5 shows you the example how the antigens kind of change and the different patterns between normal, more like reactive changes, because, T cells are gonna, we don't live in a sterile environment, right? So, and how it looks like when you have an abnormal population. So that is why we have figure 5 to kind of help you kind of see the full range of normal versus reactive versus abnormal.
Well, maybe this is a good time for me to ask,
Mhm.
what do you see as some of the top challenges or potential pitfalls when laboratories are bringing on this type of testing?
I think the biggest problem is, again, adopting the difference from normal. So really learning the normal pattern is really
Yeah.
key to success. And hopefully this paper will help with that. Another major problem is recognizing that T cell, kind of recognizing the biology of T cells and realizing that clonal does not necessarily mean malignant when it comes to T cells. And this becomes really problematic because as you know, especially now that we're moving towards higher and higher sensitivity with more markers, you're going to see a lot of subtle changes in small populations. And it's really important to not overcall them. Uh, and because we can actually start causing patient harm if we do that.
Yeah, that's a great point, Jean. I think we're hearing, as we hear more about TRBC1 and 2, and as they get incorporated more into our panels, we're finding these small T cell clones. And I know some have referred to these as TCUS, or T
Mhm.
cell clones of undetermined significance, similar to an MGUS or an MBL.
Yeah.
With that in mind, just thinking about the concept of TCUS, could you perhaps walk us through Figure 8 in your paper and
Mhm.
tell us a little bit about how you deal with TCUS in your laboratory?
Sure, let me do that. So, Tika, figure 8 is an example of a patient with no suspicion for a T cell neoplasm, but has multiple small T cell clones. This is actually a classic example of an oligoclonal T cell proliferation, potentially due to some sort of reactive pathogen. And as you can see here, we have these differentially colored. So there's a double positive population for a positive population that is dim to negative for 5 and negative for 7. Our panels always have, include CD57, so you're going to see that 57 positivity, which you often see with TCUSs, and as well as a CD8 positive population shown in blue and green that seems to show like differential expression of CD5, but they're also positive for 56, CD56, as well as CD57. In these kind of cases, so TCUS is generally, in the original study from Mayo, they showed that, the group showed that TCUSs show a lot of immunophenotypic overlap with LGL T cells. So so it's really crucial for you to really understand, what does an LGL T cell immunophenotype mean, right? They're usually CD8s, and they usually have like dimmer 5. They may have more like 57. And some of them can also have like, double positivity, kind of like in this case. And generally, TCUSs, unlike LGL leukemias, tend to be, the number tends to be smaller. It's kind of like, NBL versus CLL, right? So in this case, the double positives as well as the CD8 positive population, the cutoff, the recommended cutoff is 15% of lymphocytes or 20% of lymphocytes if you want to be a little more stringent. But in this case, all three populations are below that 15% cutoff of lymphocytes. And if you calculate the absolute count, we recommend about 500 cells per microliter to kind of go into where things kind of where you're kind of debating whether it is a true TCAS versus something more like ominous, like a LGL leukemia. And in this case, all three populations are actually well below that 500 mark.
Yeah, great. This is a wonderful example of that concept. Thanks for sharing this case.
Mhm,
It sounds like it's not just about finding a T cell clone when you're thinking about
mhm.
evaluating this data, but also thinking about the immunophenotype of the population and the context and the number of monotypic cells that you see. And I think this is something that we see all the time. Now, what do you do in terms of reporting? How do you report a case like this?
So in cases like this, I actually don't put this as an abnormal population in the bottom line because as we know, pathologists are new to like, TCAs, so are oncologists. So um, again, trying to reduce harm. And in these kind of cases, we actually put it in the comment that we say, yes, we do see multiple small populations with more of an LGL phenotype. It is an oligoclonal pattern and is favored to be reactive. Not everybody may have the clinical correlations to kind of kind of push it all the way in, but you can favor it. And we should be kind of moving towards that instead of just reporting out as an abnormal population.
That's wonderful. Thanks so much for sharing that approach. I think that is a great way to handle this type of case and to avoid overcalling these small T cell clones, which both, as you noted, us as pathologists and as well our clinical colleagues are still getting used to.
Yeah,
Is
and to
it?
be fair, yeah, you also see these populations also in the bone marrow and also in the lymph nodes. In those specimens, you won't be able to calculate the absolute count, but you can still use the percentage of lymphocytes and the immunophenotype to kind of steer you towards TCUS versus not. But it's the same kind of practice that we adopt in those types of specimens as the peripheral blood.
That's great. Well, thank you so much, Jean,
Mhm,
Dr. Oak, for giving us this tour through your
mhm,
paper and sharing with us a little bit about the way that you approach these neoplasms.
mhm.
Um, with that, I think we can conclude, and thanks so much for your time.
Great. Thank you for having me.
All right, well, thanks everybody for your attention. To see the entire article again, please visit Clinical Cytometry. This is an open access article, so you should have access to it if you go to the website. If you'd like to hear more about T-cell neoplasms from Dr. Oak or other experts in the field, uh, please become or consider becoming a member of ICCS, and there you can access a number of very valuable resources, including these. So I've included here an article from the newsletter on this topic, and a webinar with the link there to flow cytometry and detecting abnormalities in T cells. All right. Well, with that, we're going to conclude this presentation. Thanks so much for your time and see you next time.